Our first speaker is Dr. Jonathan Parker. He's a graduate of the University of Minnesota School of Dentistry. He has treated patients with temporal mandibular disease and/or obstructive sleep apnea for 29 years. He's a part-time faculty member at the University of Minnesota, a diplomat of the American Board of Dental Sleep Medicine and the American Board of Oral Facial Pain. He is a charter member of the American Academy of Dental Sleep Medicine. He has lectured internationally on the role for the dentist in the evaluation and treatment of snoring and sleep apnea using oral appliance therapy and the connection between sleep apnea and pain. Please give a warm welcome to Dr. Jonathan Parker.
Thank you, Janet. Good morning. Welcome to my hometown. This is the way Minnehaha Falls looks in the summer. It's about 5 miles southeast of here, just on the border of downtown. This is the way it looks in the winter. We're sort of in between right now, as you guys have noted. It was 95 degrees 10 days ago, and it's 44 degrees right now, so welcome to our world. I'm really honored to be back, and I want to thank Rich Fisher and the program committee for inviting me. I spent 18 years in a TMD practice and then incorporated dental sleep medicine into the practice about 20 years ago, and I've been doing dental sleep medicine for about 20 years, well, for full-time for the last 11 years. About 6 years ago, I was introduced to a dentist out in Tacoma, Washington, who introduced me to a new concept, and that's what I want to share with you today. How many of you treat patients with jaw pain, headaches, TMJ issues? How many of you treat patients with snoring or sleep apnea problems? What he did is he found the connection and introduced me to this concept. And it was telling that I decided to begin to introduce it into my practice. So today I want to give you a brief overview of this. This is really about a 4-hour presentation condensed into 1 hour. And the way I'd like to do it is to just give you a little bit of research background. I want to talk about the signs and symptoms of the patients that we're seeing, and then give you a bit of an overview of the therapy process, and then show you a case study just to illustrate it. My hope is that I can stimulate you to sort of expand your viewpoint. That's why I'm excited to be here speaking with this group. You guys already look at how we need to manage people holistically. And this fits that paradigm beautifully. So the focus of what I really want to do is, again, expand your viewpoint a little bit further. I now will read the card. I have no financial interest in any products. I have no interest in any companies that will be discussed today. Farrand Robson is the person who developed this process, oral system biology, in Tacoma, Washington, and he basically came up with a therapy process using devices to manage airway. Is this breaking up because of me? What would you like me to do? Stand in one place? Uh-oh. Okay. Thank you. So let's talk about these concepts. Hopefully I can explain how this manages with problems. Sleep apnea, pain, chronic health problems. These are all connected in some way. There must be some underlying source, or at least a number of them that are influencing people's bodies reacting. The interesting thing about this is I can stand up here and explain this all day, but it's difficult to explain an experience. Galileo said you cannot teach people, only help them discover themselves. Maybe I don't need this. Okay. The OSB therapy and training program, we were out at Cathedral Rock in Sedona, and those are my daughters who are climbing up over here. And they got to the top, and it opens up into this amazing valley. Now, I had stayed behind because my daughter-in-law was pregnant and didn't want to make the climb. And so once they came back down, they started to explain what they had experienced. But it's pretty difficult to explain an experience. And that's why it's hard for me to discuss the shift that patients have once we begin treatment. But let me see how we can do today with you. Here's the hypothesis. Is that anatomically many people's throats are crowded, which impacts breathing, swallowing, and speaking. Is the big one. Not breathing effectively, a couple things happen. First of all, posture tends to break. Full response. That happens, posture breaks down, we can breathe better. In addition, there's a fight or flight response. The autonomic nervous system is managing our body systems. And the autonomic nervous system kicks in because we're not breathing effectively, and it produces adrenaline. What the adrenaline does is open breathing passages and tighten muscles like the muscles in the throat to help us breathe, swallow, and speak more effectively. But this slight elevation in adrenaline response will also impact the body in a negative way. And then symptoms occur. So it increases heart rate, blood pressure, it impacts muscle tension, it impacts pain response, and hormone levels. It also increases anxiety or on-edge feelings. And so all of these things can... In the same way... You want me to stop? Okay. I said 4 hours of material. 1 hour. I negotiated with Rich. I said, I need 4 hours. He said, he said 1. I said, what about 3? He said 1. I said 2. He said 1. I said, well, I'll do 1. That's kind of how the conversation went. Thank you. So connect that, chronic pain, chronic health issues, with what happens in apnea. Patient falls asleep. There's crowding in the oropharyngeal airway, which by definition is what happens in apnea. The airway collapses. There's poor response by the body because we're sleeping. Our reflex responses are dulled. So this apnea event leads to increased carbon dioxide levels, reduced oxygen levels. The body compensates in response. There's increased effort to breathe, even though the airway is closed off. Then there's this arousal out of sleep. The airway opens, and there's another compensation. We hyperventilate to get air in as fast as we can. We need to breathe. And then the process starts again. So we've got nighttime response, and we've got these same patients and many others who have this going on during the day. So let's look at the system anatomically, just to give you a sense of some background of this. You know, we look in the oral cavity all the time, and there's a tremendous variation in soft palate and uvula. There's a tremendous variation in tongue size and in dental arch length and width. Remember, the tongue needs to come up into the mouth to stay out of the throat in order for us to breathe, swallow, and speak effectively. If a patient has a narrow or short dental arch, it impacts the ability of the tongue to get into the mouth and stay out of the throat and airway. So this whole system is impacted in the oropharyngeal area. Now, for apnea patients, what we know from the research is that the lateral aspect of their airway is narrowed. They have thicker lateral pharyngeal walls here in green. The parapharyngeal fat pads in yellow are bigger. The tongue's larger. The soft palate's longer. So we know this in apnea patients. What happens to those patients, and what happens to other patients that may not fit this but have crowding in the oropharyngeal area during the daytime? And how do these factors really influence how we're going to treat patients? Well, let's look at this a little bit more. And I want to go deeper into the anatomy. This will take you back to your anatomy classes in dental school. We look at, here's the geniohyoid. The hyoid bone is basically shaped like a mini mandible. We've got the mylohyoid, which is the floor of the mouth. We continue looking, we've got the digastric muscle, which again comes through the hyoid and is important for opening. We see the stylohyoid, which stabilizes it. We've got the infrahyoid muscles, which are stabilizing the hyoid from below. And then we've got the tongue muscle, which is really controlling breathing, swallowing, and speaking. The geniohyoid is the largest, this big fan of muscles here, but you've got the geniohyoid right here. And what we know is, in order to breathe, swallow, and speak effectively, these muscles need to be in tone. So if we look at the geniohyoid, for example, it runs from the hyoid bone right up below the geniotubercle. So if this muscle's in tone, we should see it's nice and tight here. We've got the styloglossus, we've got the stylohyoid muscle. The hyoglossus muscle is right here. It runs up through the first molar area and posterior to that. So if we build an oral device that is thicker in the first molar area, what muscle will be influenced? The hyoglossus. Again, it will shift the tone of that muscle in a way that may not allow it to maintain patency in the airway. Here you can see a person swallowing. In green are the muscles that are in tone. These muscles are relaxed, but you can see the muscles, the digastric runs right through the hyoid. You look at it from, You look at it from the other side. You also can get a sense of how this works and how these muscles are functioning together. So that's just an overview anatomically. Let's look at it graphically. I don't have a cone beam CT, but we've got cephs, and we do cephs on most of our patients. Here, I really don't have any normal patients with normal anatomy, but this is about as it gets. And even in this patient, we should see nice rounded cervical spine. This is straighter and a little bit forward. But the epiglottis, which is right here, should be at about 60 degrees, which it is. We can see the angle of the hyoid bone right here is, again, if the geniohyoid is taut and functioning well, it's going to be about that angle. The distance from angular plane to hyoid is longer in people that have trouble breathing effectively. And the shape of the tongue should actually be nice and rounded and up into the mouth, into the palate, and all the way forward. This isn't quite. And the airway should be of reasonable size. So this gives you a sense. So let's compare it to this patient. This patient has definite forward head posture. Look at the shape of the tongue. Long, narrowed airway, but the tongue, look at the shape. Look at the angle of the hyoid. The reason the hyoid is angled this way is because this tongue has completely lost its tone. And the hyoid bone is being pulled down and shifted. It's rotated. The tongue is jamming down into the hyoid. The hyoid shifts up, and you have a complete shift in angle of hyoid because there's no tone in the muscles. Okay. We're swapping again. In 5? Is that a new one? Awesome. Thank you. Okay. Now you can hear me in the back. So let's continue. So you get a sense, you look at the distance between mandibular plane and hyoid on this patient and how narrow that airway is. This patient's alive. Yeah, he's alive. He's upright and awake. Can you imagine swallowing through this airway? Can you imagine breathing through this throat and airway? And what happens when he falls asleep? The angle of the, the posture of the neck is partly in response to just breathing. He's spending a ton of energy just trying to breathe. Here's another example. Look at the difference here. Very different, very upright posture. Again, trying to maintain this narrow airway. You can see the angle of the hyoid is completely different, but again, it's lost tone in here, and the hyoid is being dragged down. You can see the shape of the tongue here. It's like a little baseball in here. Distance from mandibular plane to hyoid is not exceptionally long, but is longer than normal. So, and you can see how small the airway space is. So these are the things we can start to gather as we take a look at it. We know what the anatomy looks like. Now we start to connect what the imaging looks like. And then we add to that the reflexes. Our body is amazing at protecting ourselves and helping us survive. There are 7 different reflexes of the tongue. All you have to do is drop something bitter on your tongue, and immediately you'll find out, immediate reflex. Here are the other reflexes. Then there's the temporalis and jaw hypoglossal reflexes. This is what we call the jaw-tongue reflex. When we clench our teeth, it tightens up tongue through the hypoglossal reflex. That helps maintain airway. May give us a clue as to why we clench and grind. Then there are other reflexes of the jaw. Our jaws are helping maintain our breathing. But you look at the periodontal masseteric reflex. How hard do we know how to chew? And how does our brain know what kind of food's in our mouth? Is it a bagel or is it a piece of toast? Then we look at the patient clinically. And this is where we really see the connection. The tongue's trying to get up into the mouth, but there's no space. This is what we now connect to what we see in the x-rays. So you start to get a picture of what this patient population looks like. And then what is the patient experiencing in response to this situation? So the physiologic response to this situation we'll talk about in a minute. What's the impact on their pain, their sleep, on their health? And then how does that impact what we do? System is incredible. When you look at how it all fits together, the tongue and the muscles and the teeth and the reflexes, how is it that we don't bite our tongue all the time? How is it we're not biting our cheek? How hard do we chew? How do we know all that? This is all happening because our system is coordinated in such an amazing way. So let's look at how these anatomic factors affect our patients. These patients are patients that saw me for sleep apnea, but also had other pain conditions. This is a 55-year-old male, snoring, excessive daytime sleepiness, witnessed apneas, and difficulty staying asleep. Why would he have trouble staying asleep? Because when the airway closes off, the body goes into fight or flight mode. The heart rate goes up, the blood pressure goes up. When they wake up in this situation, their heart's racing, even though they may not be aware of it. And it's hard to fall back to sleep. He's got mild to moderate apnea, but he's also got headaches twice a week at a pain level of 5. This is what he looks like from the side. This is what his x-rays look like. And you start to get a sense. You got a little dimple here in the tongue, and you've got a longer tongue. Look at the hyoid bone. Again, it's the same sort of anatomic situation that I showed you in the patients before. There just is not a lot of space for breathing and swallowing. And look at how he's compensated with his posture. So let's take a look further and just get a sense, because now we start to look at the study models and see how this may be influenced or influencing the situation. You take a look at the asymmetry here in the mandibular arch. And you start to look. Now remember, I told you the tongue needs to come up into the mouth to stay out of the throat. But it's being blocked out here by these molars. So the tongue can't get up onto the occlusal surface and get out of the throat. You can also see it here. So the tongue comes up, it's deflected across the arch, and then you start to see changes in bone. There's some resorption in the bone here as the tongue is applying pressure. So we start to see patterns. What we do in our office is we manage people based on the patterns that we see. We gather evidence, we put it all together, and we start to see patterns that start to connect. And this is what we see in these patients. You look on the maxillary arch, again, significant asymmetry. Look at the length of these maxillary molars and not get up into the mouth because the molars are blocking out the tongue. And if the tongue can't get into the mouth, where's it going to go? Into your throat. And that's why we see this. Again, what we're trying to do is connect the dots here. Here's another patient, 32 years old, snoring, excessive daytime sleepiness, again, hard to stay asleep at night, moderate to severe apnea, headaches daily at 2, severe headaches 4 to 5 times a year. And I could put 20 or 30 different patient situations up here, and they look, some of them look different until you really get into evaluating them and gathering the data. Very narrow dental arches on this patient. You can see he's in crossbite in the posteriors. Here's his x-ray. Look at this. Look at this. It's like the tongue has a kink in it. Very straight neck, long, thick, soft palate and uvula. Look at the tongue. There is just no space for it. Angle of hyoid. Distance between mandibular plane and hyoid. Here's what his study models look like. And what you can see here is just how canted his dental arches are. And look at how shifted the palate is. Again, this is a lot about growth and development. But why did he develop this way? Why was there growth and development in this pattern? You start to get a sense of his growth. Things completely shifted. So let's take a look at how this is all connected. You know, patients with sleep apnea, TMD problems, other pain problems, other health conditions, bruxism. How might this be connected? And this is the hypothesis. So let's look at some of the research. And again, I could spend a half hour, 45 minutes looking at the documentation. I pulled out a few articles just to give you a sense of it. We know that about 12% of the population has a TMD problem. 77% of the orofacial pain patients reported reduced quality and quantity of sleep, either related to sleep apnea or some other sleep condition. Subjects who describe sleep difficulties are twice as likely to report jaw problems or jaw pain. So you've got a connection between sleep and pain. Both ways. Sleep can impact pain problems, pain can impact sleep problems. What about headaches? Well, what we know is 9% of the population, general population, has headaches. 34% of sleep apnea patients have headaches. And when it's resolved with CPAP or oral appliances, 90% of those patients have their headaches resolved. Again, there's a connection here between breathing and pain. This is a great workshop that was done at the National Heart, Lung, and Blood Institute in D.C., and they brought in all of the leaders in the field in sleep medicine and TMD and pain. And what they said is that TMD patients are at greater risk of cardiovascular disease, as are sleep apnea patients. Sleep apnea patients and TMD problems both impact autonomic response. We know that. So the muscles of mastication and the muscles of the tongue both play a key role, we know, in breathing and swallowing. So we start to see this connection supported in the literature. What about bruxism? Well, one of the most common reported risk factors for sleep-related bruxism is sleep apnea. What's really fascinating are these two studies that showed that rhythmic masticatory muscle activity is one of the ways that they describe bruxism. And if you look at the data, people who grind their teeth fewer than 4 episodes an hour of sleep are more likely to have pain than people who have masticatory muscle activity more. If you grind more, you tend to have less pain. That's basically what this is saying, which flies in the face of what we've been told for all these years. Because the reason we have pain is we're overusing these muscles, right? They become fatigued and then pain occurs. What these studies show is that the more they were grinding, patients had less pain. So what's the connection then? For people with sleep disorders, most headaches and jaw pain experienced in the morning are not a direct consequence of the bruxism. The bruxism is to help maintain airway. The pain is influenced by the fact that we're not breathing well. Listen, what's the one thing we have to do in order to maintain our life? We have to breathe. And our body will take care of that. So based on the current research, pain disrupts sleep. Disrupted sleep in turn aggravates pain, and oropharyngeal crowding may be a primary source of both conditions. So during sleep, we already talked about this. If there's crowding in the throat, it can influence bruxism because when we brux, the jaw-tongue reflex stimulates the tongue to open the airway. Also, it can lead to, crowding in the throat can lead to sleep-disordered breathing, snoring, and apnea, which in turn causes a sympathetic response. Autonomic nervous system kicks in. And that influences cardiovascular risk and pain. And the pain in turn can influence cardiovascular risk. But it's the oropharyngeal crowding that may be the connection to all of this. So why is this increasing? Why are we seeing so much more of this in the population? Why do we have so many more people with apnea? It isn't just obesity, although that's a factor. And why are we seeing so many more people with pain conditions? Well, one issue, or a major issue, is craniofacial growth. Evolution leads to changes in craniofacial growth, and we've seen a huge shift from this to this. See, the midface is so much smaller in people now. In addition, food processing affects it. We're not eating chewier foods, harder foods, which stimulates bone growth. There's a study that looks at that, and we're eating much softer foods now. And genetics. Genetics will influence it as well. We're more of a global community now, so we tend to have more crossover of genetic patterns. This is a great example of the evolutionary change. This is humans currently. This is humans in the Neanderthal times. And one of the most, I think, glaring points to make here, look at the throat and airway in these people. Very small here in modern day humans, much more airway space and for breathing, swallowing, and speaking back in Neanderthal time. So we are seeing a great change in evolution. All right, so let's get down to how this affects patient care. In 2007, Steve Jobs, and regardless of what your opinion of Steve Jobs, he was a visionary. And in 2007, at the Big Mac conference, Steve Jobs said, "Today, Apple is going to reinvent the phone." And people were going, "Come on, what does that mean?" It's unbelievable the impact that that statement and that technology has had on the world. He was right. He not only changed the phone, he changed how we communicate. And I'm not suggesting that the information I'm going to give you today is going to be as impactful as the iPhone. But these concepts have to cause you to step back and go, wow, that's compelling. So what about during the daytime? Well, if there's crowding in the throat, we talked about the impact on posture. We talked about the increased sympathetic response. And the body will be impacted by that sympathetic response. We are much more on edge. Hormone imbalances, chronic pain, cardiovascular consequences. When in history have we ever seen cardiovascular impact like we've seen in this society? Maybe crowding in the throat or oropharyngeal crowding is a piece of it, for all the reasons I just talked about. So what conditions respond well to this therapy? Well, conditions that seem to connect with an imbalanced and autonomic response. And many of these are not very well defined, like fibromyalgia. It's a collection of symptoms. What about ADD? What is ADD? It's a description. It's not a diagnosis. It's a description of people that can't focus and control. They get distracted easily. They're hyperactive. Chronic fatigue syndrome, chronic pain conditions, and other health conditions. We're not able to really get a sense about what underlies it. And I'm not suggesting that this is the only reason. You guys know well enough when you start to look at all of the disciplines that you're exploring that everything is connected here. But what I do know is if we don't breathe effectively, our body will compensate. And, we're using these muscles. The lateral pterygoid it's a secondary breathing muscle. What is the function? When it contracts, the jaw moves forward and opens the airway. These other muscles are also involved in that. You look at the jaw closing muscles. We talked about the jaw-tongue reflex. Again, secondary breathing muscles. They're used in breathing, swallowing, and speaking. This is an amazing system, and all of these muscles are working together in coordination and cooperation to help us be pain-free and to function normally. Breathing. 70% of breathing is through the diaphragm. In other words, if we use diaphragmatic breathing, 70% of normal breathing is expansion of the diaphragm. 30% is in the neck muscles. But how do you watch people breathe? They're recruiting these neck muscles. And what happens when that occurs? Well, what happens is that these muscles start to fatigue. And you start to experience pain in these areas because you're not breathing effectively. And when you're trying to use your diaphragm effectively in a crowded oropharyngeal area, it even adds more stress to the system. So what's the intention of this OSB therapy, oral system biology, and what is it? Well, it's basically use of appliances as the treatment modality in addition to educating patients about what's happening in their system. And the appliance is contoured in a way to balance the oral system, which helps to open throat and airway. It modifies autonomic response, which in turn reduces muscle tension, pain, and on-edge feelings. And this response is measured physiologically, and I'll show you that in a minute, using various physiologic monitoring and x-rays. So when the patient comes into the office, and this is something you guys deal with all the time, my greatest challenge when the patient comes in is to help shift their paradigm. Because when they come in with some pain condition or other health problem, they've been told by 10 different physicians 10 different stories about why it is occurring, right? So much of the first visit is explaining the concept and how it may be connected to their situation. And that is a huge challenge because they are involved in a different paradigm. And it's hard to get people to shift when they've been given the reason that they're experiencing these symptoms. So in addition to going through a history where we will try, what I'm doing is trying to get them in touch with what they're feeling in their body. When this is crowded, chest pressure is there. They tend to clear their throat a lot. They yawn a lot during the day. Why? They're trying to breathe. They're trying to get air in. And then they may have all these other symptoms. They may have on-edge feelings without knowing why. They can't sit still. Why? Because when they sit down and relax, what happens to the throat and airway? It relaxes. And it starts to close. And so the autonomic nervous system isn't going to allow that to happen. And so there's an adrenaline response. And so either they fall asleep or they get up and they start doing something. They can't sit still. So when I start to describe this concept, they start to go, wow, that's neat. Then we do some physiologic testing, which I'll show you in a minute, and we develop a hypothesis. Is it possible that this oral pharyngeal crowding is impacting what's happening in their body? So we'll do heart rate variability monitoring where we can get a sense of what's going on. We'll hook them up to a critical care monitor so we can see what's happening with EKG, heart rate, oxygen levels. And once the patient says, I can't live this way anymore, I really want to move forward with this, then what we'll do is we'll send the case out and Dr. Robson will design the appliance specifically for their situation. And basically what we're trying to do is build a pathway for the tongue to come up and out of the throat and be supported in the oral system, in the oral cavity. And this therapy is totally counterintuitive. I was skeptical for the first year for the first 3-4 months that I went out there. I thought, come on. You're going to put something in their mouth and it's going to build more space. Now, how's that? It's all about position of tongue to open throat and airway. And that's the genius that he has discovered over and over and over again in his patients. And it's continuing to evolve. He's been doing this for 25 years. So once we get the appliance in, we have the patient assess how they feel. So they're telling us how they feel. I can see when autonomic response shifts, you can see changes in skin tone. You can see people start to get clear. Posture shifts a little bit. But more than anything, they'll tell you how they feel and what's shifting in them. And we're monitoring it through physiologic monitors and x-rays. So here's an example of a patient where we're looking at heart rate here. It's just an oximeter, but you look at heart rate and oxygen levels. And once we start modifying contours in the appliance and trimming down contours, adding contours in certain areas, all of a sudden you start to see things shift. And at the same time that the heart rate is dropping, the patient is telling you, you know what, I don't feel that shoulder pain so much anymore. My jaw feels more comfortable. You start to see changes in the EKG, and I am not an expert on EKGs. But you can start to see the chattering in here, which is, I believe, and Robson believes, is a lot of chest pressure occurring. And you can see what happens once you get things balanced. It smooths out. So what we're trying to do is manage patient symptoms. We do not treat, or I do not treat fibromyalgia. I do not treat chronic fatigue. I don't treat any other health problems. I just treat head and neck stuff. Right? But it's amazing what you see. I'm just saying. I'm a dentist, so I have a certain scope of practice, and I maintain that scope of practice. I'm just trying to manage head and neck stuff. But other problems sometimes seem to shift. So how and why does it work? Well, again, if the throat opens, posture comes up a little bit, autonomic system becomes balanced, chest pressure and intracranial pressure tend to improve, the body system starts to balance more effectively, and then we see people calm down. We see pain start to improve, and their body functions in a more balanced way. So let me show you a case study. This is a 42-year-old female, chronic headaches, neck and shoulder pain, chronic fatigue, fibromyalgia diagnosis. Look at her blood pressure. Look at her heart rate. Resting. Significant chest pressure. Her heart's always racing. She did have some mild apnea.
As long as I can remember, it really came to a head in my early 20s. TMJ, headaches, daily, all day. I've done a lot of physical therapy, a lot of not alternative things, but a lot of doctoring, trying to come up with answers. High blood pressure, racing heart rate. I've done, all the cardiograms and echocardio things, and never really got any answers to why I felt so bad. And issues with fibromyalgia, chronic pain. I've been headaches all the time until about 5 years ago, before we started the treatment. It was pretty bad, and couldn't get my heart rate down. Under 100, 110 was a resting heart rate for me. Chest pressure all the time, headaches, feeling like somebody was standing on my chest, panic attacks, a lot of anxiety, and just I knew something was wrong, but couldn't get any answers. And very frustrating. And but knowing something was wrong, but nobody has been able to identify it yet. So very hard place to be in, and very emotional to deal with that. About at the point where I was ready to quit working and go on disability possibly, because I was about at the breaking point where I wasn't going to be able to do much more and still be able to cope and survive. And it affected me to the point where, even relationships with being able to do things socially, there wasn't a lot. The important things, my family, of course, was my primary focus, and all my energy went to that. It really affected the quality of my life. And so this was just a godsend for me. And even before I began treatment, just knowing that, or hearing about it, it was just like a light went on that, oh, that's me. That's exactly how I feel. And I just remember such a feeling of hope that I knew deep inside, whether anybody else recognized it or not, that there was an issue and nobody had found the answer yet. And this was going to be it.
So that was part of the interview with her. This was 5 years ago. And if you take a look at EKG, what you'll see, the typical PQRST waves, and what you'll see is there's a rest period here for the heart, which is really important. Now, if you look at her EKG, what you're going to notice is, look how rapid these are. Look how the amplitude, the spike is so high, and the rest period is so small. And this is a premature atrial contraction. Here's a premature ventricular contraction, and you compare that to what's going on normally. There's just no rest period. Her heart is racing all the time. That does not feel good. This is a heart rate variability monitoring, and the way I like to describe this is the heart rate variability monitoring looks at sympathetic and parasympathetic balance through heart rate variability. And basically, if we were to look at this, Lance Armstrong is up here. Okay, he's at 1 and 1. And what that means is he has incredible reserve, and very few of his systems are in trouble. Where is she? She is in big trouble. All of her systems are involved, and she has no reserve, which is basically what she told you, right? She's trying to survive. When we look at it from another level, and you look at what we really want is we want a patient, when they're balanced in here, +1 to -1. This is the parasympathetic scale. This is the sympathetic nervous system. Her sympathetic nervous system is revved up, and she has the parasympathetic system is rest and restore, right? And the sympathetic system is fight or flight or survival. And she is in survival all the time, and she has no capacity for rest and restore. This is a very serious place to be. Patients at this point are seriously wondering if they're going to make it. And this you can't see very well. I apologize for the quality, but this is not a digital x-ray. This is about 5 years old. But just to give you an idea of what her situation is, her tongue is just crowding her throat tremendously, and there's no tone in the tongue muscle. And this is that's her airway space, and this is the shape of her tongue, and it is all right down here. So we placed the appliances in 2007, and she wore them day and night. She was evaluated. I saw her 3 or 4 times a month because she was in such a difficult place. She would get better, and then it would recur. And then, because we're trying to balance a system that's been programmed over so many years to function this way. And every 7 to 10 days, until finally, after about 6 months, things started to stabilize. And you can see her tongue is all the way up into her mouth here, even when she's open. And then we placed the mandibular advancement device after about 5 months to help her sleep at night and improve that. We continued to monitor each time we saw her. And then we started to expand the therapy process a little bit. We got her into working with some, looking at her diet and foods that may be influencing her pain response. She did some new physical therapy, and I don't know if you're aware of PRI physical therapy, but it is profound. Also working with autonomic response. And she's been doing that, and her symptoms and health have continued to improve. This is just a picture of her nighttime appliance, which I want to make sure I have time to finish. But okay, 1 year after we started, look, she's moving into the green. Her system is responding. And look, oh, sorry. Her system is responding. It's not great, but we're getting there in 1 year. Big response. She spent years doctoring, years. This is where she was originally in 2007. This is where she was in 2011. It's like, whoa. Look at, she's now got a period where her heart rests. Look at her heart rate change. Even her blood pressure, which on this day she came in because she was having, you know, a little flare-up. It wasn't anything like her original flare-up. We started treatment. And so tell me a little bit about what you experienced once we started treatment. Remember, we put the appliances in and did some adjusting. And so what was it like for you going through the process, and how did things change?
Well, the first time I got the appliances, when we initially got them, you know, adjustment period and stuff, my initial reaction was, oh my gosh, this is what it's like to breathe. I didn't realize I hadn't been breathing for a long time. And this is what it feels like to relax and let that anxiety go and just breathe, was my initial reaction. But to have some of the pain issues be able to be controlled by how the appliances were contoured, and even just taking in and out within a few minutes was huge. It was huge, and being able to manipulate that.
So you could tell when we took the appliances out to adjust them and so on, you saw a difference in how you felt between when they were in and when they were out?
Big time. I remember sometimes you'd take them out to adjust, and you'd have one on the tray while you worked on the other one. It's like, can I have that back, please? Yeah, immediate response into how just the level of calmness in my body, the chest pressure being released. I could feel my heart rate come down, just a sense of relaxation, pain. You know, take them out and it's there, and put them back in and it's gone. And gradual sometimes. I think I was wound so tight that, you know, it would take a while sometimes. But at the end of our session, I was definitely noticing big changes in how I felt.
So over the course of... So her symptoms improved from the first day of treatment. Now this doesn't occur in everybody, but if we don't see improvement the first day, generally we don't go through treatment. That's like in my TMD practice, we put an appliance in and we say, I'll see you in about a month. And then what? Well, you hope that everything settles in, right? But wait a minute. If we're really shifting things, shouldn't we be able to measure it? Shouldn't we be able to see a response if we understand what the underlying source is? That's the difference in the concept. And I'm not going to stand here and tell you that this works for everybody. But I would say 75 to 80% of my patients, and these are patients with chronic problems. My TMD practice, some of them were chronic and some of them were more acute. Now it's basically all chronic pain issues. But it's a big shift for people that have been trying to find the answer for years. You guys know this just from your experiences in your dental practice related to other health conditions. I'm just giving you a different viewpoint. Her headache, neck, and shoulder pain significantly reduced. The fibromyalgia basically resolved. Fatigue occasionally, and she does. She has weeks that are better than others, but for the most part, she's really doing well. She's sleeping well, and what she said in the video before I turned it off is, I have my life back. All right, so whenever you go to a presentation, what's the one question? All right, what's the point, right? Get to the point already. Well, here's what I'd like to suggest. The anatomy of the oral and pharyngeal areas impacts breathing, swallowing, and speaking. Basic biology. Crowding in the oropharyngeal area leads to compensations by the body, which in turn lead to symptoms. The oropharyngeal crowding may be a primary cause of apnea, bruxism, TMD, other pain conditions, and maybe other chronic health conditions. At a minimum, it is going to exacerbate them. Assessment of treatment response can be done through evaluating the patient's symptoms, the patient's physical response, physiologic testing, and x-rays. I would strongly encourage you to consider learning more about this. It's fascinating to be in the presence, fascinating, it's an honor to be in the presence of people whose health shifts. I don't have to go in, you already know that. But all you have to do is listen to this woman, one of many. So if you want more information about what we talked about today, really the place to call is to call out to Tacoma. They're the ones that are teaching. I'm just here to tell you something that I thought was important, and I thought you should know, because nobody else is talking about it. And he's doing courses out there, but, one step at a time, one dentist at a time, or a group of dentists at a time. And we need more people out there doing it, just like you need more people out there doing what you're doing. I just think it'd be helpful to expand it. So we have about 1 minute. Rich, can I have 1 minute? 2 minutes. 2 minutes? Question. I'll repeat it. Anybody? What do these appliances cost? It depends on what you're planning to do. For her, she had upper and lower appliances. The cost, a lot of the patients, I just use a lower appliance. The cost is it's less than $500 to have it custom designed and custom made. But you have to go out and be trained in order to understand, because adding contour in the wrong place can be a big problem. That's his whole thing, yeah. That doesn't, I'm not involved. Disclaimer. You have to go learn. That's the process. You'll call out there and he asked what's the cost for the appliance, what is the cost for the training. Call out there and they'll give you all the information. It's 800-977-1945. Waited 5 months. Well, because I was not as knowledgeable at that point, and we were trying to manage her pain. And I didn't want to overwhelm her. She was already, this was really a serious case. And so I wanted to, what I had to do was I had to allow her and her response to dictate how quickly we would go, because we don't want to go too fast or it could really set her into a tailspin. So that's why. It's a great question because it makes sense to do it, but we really had to be respectful of her system and how it was changing. One more question. Do we do pre-treatment monitoring at home in order to look at patients? In some cases we do, related to apnea, but we have a sleep physician that always reviews it and then gives us the diagnosis and orders to move forward with the treatment if we're going to use oral appliance therapy. And they may want to do different testing afterwards, but generally the patient needs to see the physician after that testing. The home study is not a formal sleep study, but the sleep physician may want a formal sleep study if they think that the patient has apnea. Thank you.
Thank you, Dr. Parker.
We have no idea what's
The
going on.
AGD code